Yeah, thank you. Thank you. As I mentioned earlier, so I'm presenting this for Dr. Luis Davis, and who is a resident in OBGYN here at EVMS. And she wasn't able to make it. So I will be presenting this for her. We have done this before together. So I'm not going to be that great like Dr. Luis Davis. So, like bear with me, okay? And so the topic is implicit bias that we've been working on. And let me see how this works. And to begin with, I don't know if you all had a chance to fill in the pre-survey. If you haven't, would you take a moment to fill this out? It's short and it will be very quick, and it's very important for Dr. Davis.
This is is this the one that we already uploaded into the RedCap system, McBid? Or is this specifically the IAT?
I think it's the RedCap system. Can you check, please?
Oh, yeah, because they may have already done it already, so they don't need to.
Okay. If you have done it, then that's
good. They don't.
And we can go ahead. Yeah. I wanted to make sure that we didn't miss it. Okay. Okay. Great. So really the areas that are covered, the takeaways should be having some strategies for bias awareness, some skills to counteract bias, to identify thoughts, actions, and phrases that stem from bias, and then to be able to analyze your own implicit biases using the association test. So those are the takeaways that we want to talk about. And now, we can all agree that there is, tremendous intentional, structural inequities and the prejudices and discriminations broadly in our society and in the healthcare system in general, and that actually tend to affect outcomes in a major part of our population and communities. However, we also think that there is a large amount of unrecognized bias that is in the system, and that is also among individuals that make that challenge even broader and more. And that is the reason that we think that implicit bias training might be an important thing to do in the healthcare system. And of course, when we look at Dr. Martin Luther King's phrase here, which has been really emphasized numerous times, that there is no form of inequality or injustice that is more, harsher than injustice in healthcare. And I mean, and all of those things are actually are results of the systemic and explicit, injustices and the prejudices that exist, but also the unrecognized, the simple little ones that actually happen every day in our systems, be with the systems, but also, with individuals like us, right? I mean, that is the question that we want to address. And I think, this needs no explanation to this crowd. The groundbreaking report that came out in early 2000s that actually established this thing, that there is a health disparity that exists in this country, and it is manifested through, with higher morbidity and mortality in certain groups, and a poor quality of care, as well as, like worse outcomes. And that is really targeted at certain groups and not in others. And so those are what, were defined as disparities. And so these are, disparities that can be actually avoided, but they are there because of the ongoing biases and inequities that exist in the systems. And they manifest in numerous populations, when we look at, like adolescents and suicide rates, and when you look at Appalachian white, the community with higher premature death, with COPD and accidents, African Americans with higher infant mortality, more likely to die with AIDS, and more likely to be blinded with glaucoma, Hispanics with higher deaths from DM, and higher rates of HDN and BMI. All of those things are actually manifestations of these differences and disparities that exist in our society. And then, we all have in our, communities, wherever we are in those healthcare systems and medical schools, there are these zip codes right next to us that manifest in these pictures, of high rates of diabetes and high rates of blood pressure that are, concentrated in certain areas and in certain communities, because obviously there have been years and years and years of, actually intentional and structural inequities that have been built up to create those. But then, systems that are actually existing and perpetuating some of the explicit, but the implicit, the biases that actually perpetuate these outcomes over and over again. So what are your understanding of implicit bias from your past readings and explorations? Can you share with me? Just shout it out. If I can hear you, obviously, but maybe not.
It's only so how would I define implicit bias?
Yeah.
Essentially a preconceived idea about a certain group or a certain party that could potentially impact your action to favorably or unfavorably affect that group.
Perfect. That's great. Any other thoughts on that?
I think some of them also we're not aware of it until something happens and someone tells us in the situation that was implicit bias. Some of them are unknown to us. We live with that, unfortunately.
Yes. Thank you. Very, very good points. And those are two very important points that they are, we are not aware of it, and it actually affects our actions and thoughts. And so let's make some, do some thought exercise. Can you think of a time when someone made assumptions about you that was biased? Anybody want to share? Yes.
I have a funny story. Yeah, I have a very funny story. It was actually one of my med school interviews. So when I was interviewing at insert school here, Wayne State University, I was on a one-on-one interview and they looked at me. They're like, "Oh, so what position in basketball do you play?" Oh, excuse me. This is a funny story, and I was like, actually, I was in sports, college wrestler. Oh, you're a little skinny to be a wrestler. And I was just very taken away by. This was attending, mind you, that like one, he assumed that I played basketball, and two, that he kind of like stereotyped me based on how I looked.
Yeah.
Needless to say, I did not go to that school, and definitely will not be applying there for residency. But yeah, that's my whole story.
Thank you. Thank you for sharing.
I mean, I think if people, usually, you know, the first thing that you ask them, they will ask where you are from, and they would know where it is placed, and they would always assume that I dress up the way that I'm dressed up here in US, and when I go home, I'm covering my head or I am wearing a hijab or something like that. Like they totally do not have any understanding of where I'm coming from, and there is nothing wrong if I were wearing a hijab. It's just like ignorance putting me in a different group that I'm not part of it, you know?
Yeah. That is a very, very common question, right? That you get people asking where you're from. And then the most interesting thing is like they don't believe you afterwards. They just keep on asking, but where? But really where? You like you say from the Bronx, and then no.
I will tell you a funny story because my kids are first generation, so they look white. One of them is darker, and one of them is white. And then they cannot put her in a categories, and they say, "You're whitish," but actually, like, where are you from?
Yeah, that really happens. And then the second one is definitely a very, I'm sure a lot, you know, everybody who has been in the clinical area have witnessed something that where, you know, it doesn't have to be a physician, but where you can see some bias in the clinical area. Any examples? Yes.
I was just gonna say that. What? I was just gonna, in the clinical aspect, I've seen a lot of the time. Well, I work in an urban city, New Jersey, and a lot of the patients that I have are comorbid. They have like diabetes and just heart failure, and a lot of times we come to their place of residence because they're suffering from the effects of their illnesses, and they oftentimes don't take the medication. So I've seen a lot of my partners make assumptions that they're not compliant because it was some internal trait that they had, and not necessarily because of the barriers they had to access the medications that they need to have. And unfortunately, I feel that's way more commonplace than people give it credit to or acknowledge. And it's just unfortunate that the patient's full story isn't really being represented as it should.
Thank you for sharing. And obviously, you know, it's we also have to realize that, you know, we are not, you know, free of that ourselves. So there are, you know, like when there are times when we catch ourselves, right, you know, like being biased or experiencing some kind of bias towards others, and then we kind of or somebody tells us, which is a good thing. That's when that happens as well. Any example of that when you found yourself? Yeah, it's okay.
I was going to speak on a story of when I saw a physician being biased. I once was shadowing a surgeon who would pass off patients who were above a certain BMI because they didn't want to operate on people with like large amounts of body fat. And I think that was an example of explicit bias. But it was still just like accepted in the practice setting. People knew him as that sort of surgeon.
Yeah.
He was considered a really good surgeon, but he wouldn't operate on people above like 35.
Yeah, and I think, like I'll show you later, there is actually some research in terms of bias, physician bias against people with weight, that is really thin. So as you mentioned earlier, the fact that it's implicit is that it's unconscious. So at the conscious level, we wouldn't think that we are biased or prejudiced, or we wouldn't think of that. But the biases and stereotypes do not make us necessarily engage in discriminatory activities. However, we see evidence that that biases tend to actually, at one point or another, trap us into making discriminatory, thoughts or actions or, outcomes that in the end, translate to something that could injure or hurt someone, that we are biased against. So in most cases, it is really a question of, like, oh, while people are, considering themselves, like, no, we're not biased, we're open and so on, they might be engaging in biased activities. And that is actually the worst part, because, like, this would be individuals that are actually consciously working, right, towards, like, being unbiased and towards egalitarian values, but then, like, you could get trapped into biased behavior or activity. And the most important thing about this is that that it is a natural and normal thing. So it's a normative, unconscious behavior that we have, like, adopted to navigate our world, right? Like, to process information quickly, to make decisions quickly about, like, danger or the opposite of danger, like things that are, good for us, so that we can actually manage the world of information, because we get, like, millions of, bits of information every second, and we can't stop, right, to process it and look, for the right answer. So we have, like, all these patterns that we, accumulate. Yeah, and it's accumulated with different reasons and socializing socializing experiences that we go through, and then we make those decisions are made without our knowledge, and then the worst thing is usually they kind of stick, and then there are outcomes that are associated with it. Now, the instrument that has been developed, to measure this and see, like, implicit bias in action is the implicit association test, which was developed by Greenwald and Banerjee. And the way that this evolved was actually, Greenwald was a psychologist. He wanted to see how implicit associations work, right? Quick associations that we make unconsciously, how do they work? And he was testing with insects and flowers. So he had, like, a set of insects, a set of flowers, and then he tried to see how we can, match it quickly with good words, with words that we think are good and words that are bad. And what he found in that experiment was that people found it difficult to associate the bad words quickly, with the flowers, and the good words quickly with the insects. And then when he found out that this was really working, he just exchanged the flowers and insects for a black face and a white face, and he tested it on himself at the beginning, and he found out that actually he had trouble associating quickly the good words with the black face and the bad words with the white face. And so then that's how this test evolved. And now, it has been, done by millions of people, validated in that way, because it's really out there, open and and available for anyone to take it. And there are, numerous categories now for the test. I'm sure, all of you have done the test, so you know it. And then when we see in the clinical area, so there have been a number of projects done, research done in the clinical areas, which showed that actually, truly, these implicit biases work and are present. And this is the first one was related to actually prescribed life-saving procedure, which physicians, residents gave to a white patient versus a black patient. It showed that implicit bias was there to actually weigh negatively for the African American patient. And then, the example you gave earlier, this was implicit bias against overweight people. 2,000 medical doctors found that they were overall, biased. And the Hopkins study also demonstrated there is like a deficit of the compassion, right? Related to that, when you compare it. And these are all studies that involve taking, having the physicians take the IAT test, and then after that, measuring, then looking at this variables. This is one study in Baltimore as well that showed, 40 primary care physicians, 269 patients. The physicians took the implicit bias test, the implicit association test prior to that. And it showed that there were, among the Black patients, they found there's poor communication, verbal dominance by the physicians, lower affect, and the patients generally rated the physicians poorly. So this is all, like some things that show us that implicit bias in our healthcare environments are definitely prevalent. So how do we mitigate it? And, first of all, we have to be aware of it, right? That is an important part. Taking the test will help us with that, so, taking the test really allows you to see your implicit preference, and implicit bias for in any, number of categories. And then, we can then be able to really work on something that is called microaffirmation, because we have, the microaggression part on one side, right? Microaffirmation is really to work to affirm others, to think, to identify and recognize the positive attributes in others in every day we do, to all recognize the good things that somebody does. Changing the norm, and changing the norm could mean getting together with groups that we otherwise don't, we really, socializing with others, having new experiences, asking different questions, and really making diversity and inclusion a goal. If we get up every morning and we say, inclusion is really my goal, like every day, in my everyday action, it is very important to take that, and then really educating ourselves. And this is a strategy to address our own biases. It's called taking charge, changing context. So, could we be looking, and we get trapped all the time very easily. We might be, doing, an admissions interview or a job interview of someone, and something traps us in them, right? Their look, the way they talk, and so on. And there may be a number of reasons for that. But it's always good to take perspective, right? Could we look at this differently? Are we being trapped because of some implicit bias that we are carrying in ourselves? It's important to be honest and acknowledge and be aware, and then to avoid blame. The worst thing that happens is that actually people blame themselves. Even, like when we take the implicit association test, if we find out that we are, it shows some bias, there's an immediate reaction to that, either, like to blame and feel guilty, or to say that it doesn't work, right? Like, so those are, some of the areas that we get trapped in. We need to slow down, because much of this happens when we are in a rush, right? When you are in an emergency situation, or when you have to make a decision quickly, that's when you actually the implicit bias kicks in, because those are like the quick forms of making decision, right? That is like the mechanism comes back to take over, the unconscious mechanism. Getting to know people, others who are different from us, and then to engage, to think about why are we even doing what we do. If the core reason of why we do what we do is to care, right? Then like that should govern all our actions and behaviors, and that at the core of that should be not judging, or like not being biased, and like bringing everybody in, right? So those are some of the things that we should. And then obviously the unimportant aspect should be empowering, and empowering is like bigger than inclusion, right? You're actually going further in including and in really making people important. So so what are, like some of the things that you can implement in your clinical spaces and in other spaces? Additional areas to address, and how can this practice be incorporated into resident learning sessions? Those are, like some of the things that Dr. Louise Davis was interrogating as she was working on this on this project. So can you think of any of this? Do you have any insight to these questions? What practical things can be implemented in clinical areas to address bias?
So implementing something like a quality review system where you look over cases. I know at Albany, we have our GFR ratings for African American patients are separate from anyone that doesn't identify as African American. And we're in the process right now of moving that label to our patients that identify as Black. And that's more of an explicit bias, but when it comes to our quality review systems, and we can even look at like physician behavior on prescribing medications like hypertensives or statins or what have you. So that'll be like a very thorough systematic review charts and looking at if there's any like correlation between like race and prescription, etc.
Thank you. Any other thoughts on any of the questions?
Yes, I'm actually going to answer that first one.
Yes.
I actually did a talk on this a few months ago. We were talking about disparities in screenings and so on regarding underserved communities. And at one point, we were discussing implicit bias and how we do have that implicit bias test that people are taking. And it's good at identifying biases, but it's not really good at talking about how to mitigate them and coming up with strategies to fix them, because we're like, okay, yeah, we know people have biases, but they're still obviously affecting healthcare. And that hasn't been fixed, even though we are very aware or becoming more aware of these biases that we do have. And one suggestion was that we came up with was to have, like, for clinical teams, to have actual workshops where they present like patient cases, and through those cases, identifying the biases that affected the way this patient was cared for. So it's not specifically listed or stated that this patient suffered from, like, was a victim of biases, but you as the healthcare team will work together and see how implicit biases could have affected the outcome of this patient case. So that's something that I think would be very practical and a lot more real for physicians and those in clinical spaces to identify their biases and see exactly how they affect the way that they provide care.
That's a great point. Great point.
I was going to ask,
Okay. I think maybe what is not addressed, sorry. I think what is not addressed here is the reverse bias by the patients towards their physicians
Yeah.
when when the physicians are not looking like them. I think
Mhm.
that's also a big problem.
Absolutely. Yes, that is correct.
Something that I worked on a couple of years ago was creating surveys for, I guess kind of talking about something that happens a lot, which is surveys. But asking residents, kind of pointed out your third question about how these practices can be incorporated into resident learning sessions. Asking residents what they feel comfortable and uncomfortable with approaching and treating. So we put out a survey to a couple residents down at a hospital in LA. And we found out most residents there weren't comfortable or didn't know how to approach treating differently able patients. And I think if you can identify that that is a learning gap in your residents, then you can start looking for curricula or exercises or trainings where you can kind of pinpoint specific areas lacking. You go, okay, now we're going to bring all of our residents to this organization, or we're going to bring this person in, or we're going to have extra training sessions on how to best care for patients who are able. And so being like vigilant about or being persistent about seeing where gaps in knowledge are, I think is a good first step in addressing it at the resident level.
Yeah. Great points. These are really wonderful input. Dr. Davis would enjoy this, absolutely. So we can we have a couple of cases to work through, and this is the first one of a 25-year-old female in postpartum day 2 from an uncomplicated delivery, and on morning pre-rounds, it's determined that she's ready for discharge. The physician noticed that she does not have anything documented for desired birth control. And then upon walking into the room, the physician overhears her speaking in Spanish and realizes she's a Spanish speaking only. That's what he realizes. Fortunately, the physician knows enough medical Spanish to ask if she's meeting all postpartum milestones. When asking if she has chosen a method for birth control, the physician thinks the patient looks confused and takes a deep breath and a sigh and realizing that now there's a need for an interpreter to properly explain, steps out. Instead of getting an interpreter, the physician thinks she won't want a LARC anyway, decides, and it would be a waste of time, and tells her that she'll be prescribed a pill to make sure to take the pill every day. 6 months later, the patient presents to the office for a new obstetric appointment. So where do you think the bias, what was, what happened here, and what were the assumptions made? What were the biased assumptions? What were the biased actions? And what were the, the outcomes?
I would say that the first biased assumption is the physician thinking that the patient wants birth control without asking if that's something that she would want. And also not asking her if she speaks English just because she heard her speak only Spanish. and then assumed that she was confused when she was confused because she probably never asked for birth control. Doesn't know what the doctor is asking for that. And then instead of telling her what kind of pills she's prescribing to her, she just tells her to take it every day. And a part of our talk that I did a few months ago that was on disparities in screening, and there was a part that focused on medical adherence and how patients are not adhering to their medication regimens. And it's because physicians are assuming that they wouldn't understand what they're taking the medication for, so they don't explain it. They just tell them to take it. Yeah. And that is what leads to non-compliance when it comes to taking medication. So I think that this physician has checked all of those boxes.
Yeah, thank you. It is. Any other thoughts? And we can actually highlight some of the things that you mentioned to us. Assumption that the patient is just Spanish speaking. And then obviously there is, an accompanying behavior, right? The sign. What does that mean when the patient sees that, right? Like you have immediate reaction that is unacceptable, and assumption that she wouldn't take Clark, and so it would be a waste of time. And then to begin with, the biggest hurdle here was explaining, right? You mentioned that, you don't want to explain anything. You just want them to tell them something, right? And so explaining becomes a hurdle and a burden. And so they have to get away from that. And it's a waste of time. That's what the physician says. So what do you think, just very briefly, what should we do if you were a student or a resident in this context, when this happens, what should you do?
Hi. So the first one that's highlighted Spanish speaking only, this is, one of my pet peeves is when they don't get the interpreter and you don't have the proper language skills. So as a medical student, I feel like we have more time at least. So if you see this happen, you can always go back with the interpreter and make sure you cover the points that you feel were missing, because maybe it's intentional, maybe there was a lack of time, whatever the case was. You can go back and ask, first of all, as you stated, would you like to know about birth control options, before assuming that was something that she wanted? And then, would you like me to go over the types of options we have available to see which one she would want? And then discussing how the birth control works that she chose at the end of that.
Yeah, that's a great point. Now, because one of the things that, when we're doing some of these sessions with students, the biggest hurdle that they see is the question of hierarchy, right? Saying, if the attending says this, can I even intervene? I think you kind of mentioned a little bit how you can facilitate that. Can you articulate it more as a student?
Right. You're right. That's definitely a tough hierarchy sometimes. And I think if you want to go about it, you can, let me see how to articulate this stuff. At the end of the day, if patient care is the goal of everyone, and so everyone wants that to be the best outcome. So you're really just contributing towards good patient care by going back and just saying, I have some extra time. I want to learn further and do some teaching methods on the options we have available. So, you could ask your senior resident or somebody, is it okay if I go back to that patient's room and kind of discuss a little bit further about their management? And often I'm sure they would say yes to that. So that's what I would do.
Excellent. That's really great. Great. Thank you. Any other thoughts before we move to the next one? Okay. So we have another case here, our second case is evening shift on labor and delivery. Male partner walks down the hallway to the cafeteria. While walking the nurse station, one of the nurses noticed a strong smell of marijuana. She did not see which room the patient came out of, but she decides to go talk with one of her young African-American patients about the no smoking policy. Upon entering the room, she does not notice the same smell, but assumes the partner probably just smoked outside before he came up. She proceeds to tell the patient the policy, and the patient assures her that neither herself nor her partner smokes. The nurse is skeptical and reiterates that she's free to smoke outside if she pleases. After leaving the room, the nurse notices the partner returns and enters a different patient's room. So, what are the assumptions? What are the behaviors and outcomes of this? And, like some of these things, is this common in the clinical area? Or is it, like we're pulling, really strange cases here? What do you think? Huh?
I think it's common. Even with sickle cell disease, patients in pain, they think that a patient is coming for drug or something like that.
Mm-hmm.
But I think it's very explicit. There is nothing implicit about this bias.
Yeah, that's the yeah. Yeah. I mean, the thing that is the implicit aspect of it, that's, of course, it does look, quite explicit, like the behavior itself. But it's like the assumption that the group that she associates marijuana smoking with is, like the pattern, that the learned pattern that is there. So it's, in the end, it could be quite a racist, explicitly racist person that is doing that, but it could also be quite a broader, like an implicit systemic question that we have here, which is as likely. So we see that, even after the patient answers, it's still not, it's not resolved, right? About the policy, because like it's something that sticks. And our third case is again, very interesting one. Hospital stay with two patients with similar last names, a middle-aged white female and an older Black woman. They happen to be discharged on the same day. Physician notices while doing the discharge medication that the white patient's pharmacy is in a rough part of town. This raises a little bit of confusion because the physician was certain that the patient was middle class, at least since she was so well put together, as he says it. And knowing that the registration desk sometimes makes errors, the doctor, plans to adjust that. And so maybe it's a switch of pharmacies by mistake. So to double check, he calls the patient and confirms the pharmacy address. The patient agrees this is the correct pharmacy, telling him she lives in the adjacent neighborhood. The physician asks, "Really? You're sure?" He's still asking. It's like that, where are you from question. What do you think about this one?
The physician is assuming that rough part of town can't be associated with white.
Mm-hmm.
That's the bias here.
Yeah, absolutely. That is, like it's a very interesting bias, right? Like it's almost kind of a reversed one where you are actually associating positive things to groups. And instead of usually what we see is, associating like negative things to groups, right? And then thinking that, like, oh, no, this can't be the case. So, of course, it's, associating rough parts of town. And then, does this, like this is a question I have. How does this interaction affect with the patient? How does this work out? What does this bring in the conversation and the clinical interaction?
I think if you make the assumption, then just the pharmacotherapy may be different because you make an assumption that maybe this Nigerian woman does not have the proper Medicare, health insurance or something like that. And because you mentioned that in the beginning of your talk that there's implicit bias when you are writing medicine for patients depending on their race. So
yeah, I think one example that I don't know if you've read Daniel Offrey, who writes quite a few books on communication with patients, and so she says she's in New York. One of her biggest mistakes, clinical mistakes, was when she saw a patient, a woman patient who is about her age, from her experience. She was a Jewish woman from Brooklyn and came and she had some chest pain. And she immediately discounted that and thought, no, this is, like she had a totally different diagnosis, but she was actually having some major problems. And so she says, assuming that someone who she feels very familiar with, right, like herself, also creates that bias, that skewed assumption that could create, like really major problems, right? So those are, like some of the things that we can see in some of these interactions. So in summary, health is comprehensive concept. We have physical, mental, life experiences, social and structural determinants. We know health disparity is, a regular thing in our society, and a contributor to health disparities are biases, in the system and individuals, explicit and implicit. An implicit bias is unavoidable and can be an adapted way to help us efficiently navigate the world. So there are ways to mitigate biases, though, to avoid negative impacts, and especially when treating the populations that are vulnerable. And we can see nuanced ways bias creeps into our daily interactions, as we see in some of the research that we saw. And it's important to intervene and address them. So if you will be kind to fill out this post survey for Dr. Lewis, I'll be very much appreciative, and thank you for being here and for sharing your thoughts and for everything that you do and you will do. Thank you.
For the cases that you gave, a lot of biases were seen as negative towards the patient, but is there any cases where the biases, as in like a doctor thinks they're doing good by the patient when they're actually not, by being biased in a way?
Can you explain that to me a little more?
As in, for example, a student is having a hard time learning, or a person is having a hard time functioning, and they, throughout their life, they didn't have a hard time because they did good in school, whatever, so they didn't get treated as they should have, because the doctor thinks maybe mentally they were okay. In reality, they were better at coping. So the doctor was biased in that way. So how could a physician be more aware of that? Because they think they're doing good by the patient when they're not.
Yeah. Well, I mean, I think there's a lot of that, obviously, because the assumptions are quite positive towards, especially when you when you are in that kind of a very a situation where you're not asking and reflecting much and actually asking your faults, in many cases, and your mistakes, which the profession kind of promotes a little too much. Then you can be trapped in that assumption all the time that you're doing well, actually, with patients. It is important, and that is why it is important to have actually always feedback, which we don't get in many cases, right? Patient feedback is not taken in many areas. You don't get a lot of like immediate feedback as to how you're doing and how you're rated. And I think that would be, the best way to address that is, to implement a system of feedback that kind of informs you where you are, and how people are experiencing interactions with you.
Thank you.
Thank you for that question. That is so important. That could be a great project, actually. Being immediate, quick patient feedback.
Thank you. We don't have any more questions. Thank you so much.
Thank you. Thank you. Appreciate it so much. Have a good one.
Thank you. You too.
Bye. Bye.